So we've talked about sensorium, we've talked about thinking. Those were the two first levels. Now we go on to the third layer, which is what behaviors emerge when you have problems or impairment in motivational circuits. And we talked about there are 4 behavioral categories. There are goal-directed behaviors, there is apathy behaviors, importuning behaviors, and motor behaviors. If any of these are present, then what it takes you to is saying it's the motivational circuitry that's off. So again, it gives you a place to conceptualize and understand, because this is both. You understanding more so what you're doing, and then being able to understand the meaning from the individual's perspective. It's supposed to work both ways. Okay, so again, nothing goes without a little bit background and history, unfortunately. So here is the history on motivation. It's derived from the Greek word movere, but it just means meaning to move. You move. And what is the definition of motivation? It's a persistent voluntary effort. I consciously do it, and it's directed at satiating, a fancy word for fulfilling a need I recognize in my body. And once I recognize the need, then it propels me to do things, actions, to fulfill that need. And when I fulfill that need, it means goal attainment. I've accomplished my goal. So let me give you some examples here. Actually, before we go. So what is a need? So need really is an interesting concept in psychology literature. So all of this stuff actually has been picked up from psychology literature. None of the stuff I'm talking about is in quote-unquote medical literature, just for you guys to know. You have an internal physiological or a psychological state of the individual. You know, whatever is happening in my mind and my body is my internal state. Then there is the external state, you know, everybody here, the environment. There has to be a discrepancy in my internal state and what's happening in my environment to identify the need. So I can only identify a need if my body detects that discrepancy. Now we go to the examples. Okay, before. So this is important. So needs, you know, if I have a need, how do I formalize that need? By generation of a thought. Thoughts then lead to identification of goals. The goals have to be met by the drives or the motivation, leading to goal attainment, and the need is fulfilled. So fairly intuitive, fairly simple, and I think once we get the examples, you'll understand. So here's the example. Register staff in hospital, they go hours without eating and drinking. So they've been working all day on their feet. No chance to stop. And then come 3 o'clock, Mrs. Smith's grandson, school's done, goes to KFC, picks up a fresh sandwich from KFC and brings it. Now, smell permeates through the room, through the nursing home, to the ward. So what happens? What's the discrepancy in that? An RN or an RPN or a healthcare staff, they've been working all day, running off their feet all day, didn't have a break. And they smell this wonderful food. What is the recognition? Hunger. I'm hungry. And what is the thought? I haven't eaten all day. Holy, I haven't eaten all day. Normally they haven't gone pee all day. But it's also not haven't eaten all day. As they say, the strongest bladders in the world are you guys. So, what is the goal? I need to get some food. And what is the drive? I'm going on a break. I don't care, guys, I'm gone. And then you eat, you satiate your appetite, your tummy is full. Then after that, they can bring the next best smelling food, and who cares? Because your tummy is full now. There isn't that discrepancy. And imagine this happening 1,000,000 times a day in everything we do. Let's take another example. I'm traveling in a part of the world that is foreign. English is not a language, and being a guy, I don't ask for directions. So I get lost. And I end up in an unknown restaurant location. And I'm surrounded by strangers, and they're talking a different language. The dialect is very loud. It's very emotive. So I'm not sure if they're talking or fighting. And I cannot communicate with them, and it starts to get dark outside. So what is the discrepancy in this situation? I'm feeling uneasy inside. I'm really struggling. I'm afraid. And I see these guys carrying on like there's no problem. Well, if they could only look inside me to know the problem. That's the discrepancy. So what does that do? It immediately says, what is the need that is being identified? Security. What is the thought? I'm feeling unsafe. I don't know the language. I don't know the people. It's getting dark. They're talking very loud. I don't know what they're saying. They might be saying all kinds of things. And well, I'd take this guy and be the, whatever at the back. Take all his money. So, what is my goal? I need to get out of here as fast as possible. And what do? I get in the car and drive like this. The road's never going to end. Because I feel safer in the car than I do among strangers. So I have fulfilled my security need. Then after that, the same people I can pass by on the road, I don't have the same fear. So it's that discrepancy between me, my inside, and my outside that identified the need. Let's take another example. I know someone who very, very strongly faith-based, negotiated with God at one time that something had to happen, didn't happen, so he was angry. He's a doctor. So he stopped doing things, started questioning his faith. And then he was treating this family, and this person was not supposed to survive. Trauma, whatever. He survived. And the family was just overjoyed because of their strong faith. They said, this is because of this. So what happened? Here's a guy who's questioning his faith because the last negotiation with God didn't go his way. And now you've got a family that is so strongly believing in what is happening, and the discrepancy. Questioning my faith and unwavering faith in their beliefs. What does that do? It identifies a need. I need to belong. What's my identity? I need to belong somewhere. I need to belong to a larger, because that's what as human beings, were very important for us to, is to belong. And so the thought, I should go see someone, some elder, maybe they can put some sense back into me. So the next weekend they do go, and that need of not belonging is now satiated, and they go back to their beliefs and their faiths and everything else. So again, discrepancy, identification of need, and the need to fulfill it, to release it, and that is something that's very important. So needs, and this is all done only if your motivational circuits are right. Because if they're not, then there can be aberrations in how you achieve all of this, and which is what we see in our patient population. So, goal-directed behaviors, we break it down into thoughts and activities. So goal-directed thoughts, always remember, these thoughts are because there was a discrepancy that led to identification of a need. And that need has to be fulfilled. And activities is they're trying to fulfill those needs themselves. But in turn, we're circling around them because it's not being done the way it should be done. Let's take a few concrete examples of this particular behavioral category. The thought is, I need to go home and feed the kids. Because maybe it's supper time, they got the smell of food. You know, there was a visitor on the unit, a little child, whatever, we don't know, because we never know. But the pairing of information, and of course, then the one healthcare person says, "Oh, John, your kids are 40 years old." Now, he is still remembering his kids to be 5 and 7. It couldn't be John, it has to be a mother, not a father. Mother has to go and worry about kids being fed. So mother. So these people are saying, "Oh God, no." And then, you don't even have a home to go to. It's sold. Your kids sold it. Now you're really upsetting this guy. Okay? You're not helping. So the more you do that, the more their thoughts lead to emotions. Emotions is the fuel for behaviors. The more you say those things, the more they're going to go past you into the nursing station, out the door. Because you're telling a mother not to feed their kids. You know, a guy, you can't watch football. Maybe that same response you'll get. But this is what we see. It happens on the unit all the time. "Oh, I live in Brampton, call my home." And I tell you, you sit there and there are 15 different answers by 15 different staff who come and deal with this patient. And by the end, he is so miffed and upset and angry that he ends up getting a PRN. And we did not help the situation. But the key is to recognize this. Same way. Another example. Someone comes to you and says, "Where can I go pay my bills?" What kind of response? "Oh, your daughter took care of them. All the paid. It's all free for you. You don't have to do anything." Now this guy wants to pay his bills because somehow through the information there was a need identified that he needs to pay his bills. But our answers are basically upsetting him because we're negating everything he wants to do. And then, of course, they start to go in, pick up the phone, and you get into a tussle, a code white is called, and the rest of it. Something we more often see than not. The guy shows up, they show up and say, "I'm late for work, where are my car keys?" Well, of course, you're retired, you're on pension, you're 90 years old. You don't have to go to work. Okay, now, he woke up recognizing a need. He looked at his clock, his watch, and said, "I'm late for work." However that idea of work came, we will never know. We can sit and spend hours trying to understand that, but all we're recognizing is it's all being processed. And the next thing you know, they're emptying their drawers, they're going into other people's rooms and they're rifling their stuff. They're looking for their keys because they're late for work. So the idea here is to recognize that the discrepancy, even when people get advanced in their dementias, their ability to determine or detect that discrepancy between them and their environment does not go away. The only thing that goes away is how it's expressed. It changes. And I mean, if you came down at 4 in the morning saying I'm late for work, no one's going to give you Haldol because you just woke up in a startle. You were thinking about work the next day. Your boss was going to give you a hard time, and you wanted. No one's going to call code white on you. So similarly for this individual, you have to appreciate that this is real. And what's interesting about this is what's the hallmark of these thoughts and activities is they are persistent and repetitive over shifts and days. You'll see it happen for the whole day. Sometimes you'll see it happen the whole weekend, and then you don't see it for 2 weeks. Or you'll see it every day for a week and 2 weeks, and it never goes away. But when they are in the midst of that, they are determined because they are trying to satiate a need that has been identified by them because of a discrepancy between them and their world. And what you're doing is, and so what that does is if it's thoughts or it's activities, we know, you will know and I know, how much unrest they cause on the unit. Like they're everywhere. People who are exhibiting these behavioral expressions, they are everywhere. You leave them here, you go try and feed, the next thing you know they're on the other end, and you have to run for them. Because you're always playing catch up. You're always playing catch up because you know someone's going to get hurt. And that is the nature of this behavioral expression. So what is the purpose of this measure? The purpose of this measure, obviously being Canadian, is to make you aware that this person is acting like a beaver before winter setting in, and they are determined and hell-bent to get what they want. And if nothing else, what it shows you that it's a very, very high energy state. But what is the person trying to tell you? Communication. What the person is trying to tell you is, please assist me to belong. Now, what do we like to belong to? Our family? Our faith, our profession or life's work, community or ethnicity. That is what we like to belong to. So when someone wants to go home and feed the kids, it's the belongingness, the responsibility that comes with being a mother. If someone wants to go pay the bills, they're worried. If I don't pay my bills, the word spreads out, the neighborhood, I belong to the neighborhood. What will people think of me? This is what's happening in their minds. And obviously a lot of this is speculative. But this is where we have to learn to understand what's happening. How many times we've seen, grandmothers feeding everybody else in wheelchair. Oh, baby, bambino, feed. Because they're misidentifying. They're a grandmother. They're feeding a baby. We have people, I remember a patient we had on South 3. He was a carpet layer all day. He would kneel down, clean, get up, go walk, all day. Try telling him not to do it. So we see this. We had doctors who become patients. They stand at the nursing station and dictating everybody. No one's listening. But that's what's happening, because the need to belong is critical to us as human beings. And what this behavioral expression is telling you, when they express this, is they're basically saying to you guys, please help me to belong to my purpose. It could be any of these. But if on the other hand you contradict them at every stage of the way, then you will have a code white. So, approach to care. Cogeco, how can I help you? Cogeco commercial, everybody knows. Your job is not to give them reality testing. Please don't. Your job is, yes, I understand you need to go home, feed the kids. Let's take from there. Hopefully, you being non-cognitively impaired will think faster on your feet than the person who's cognitively impaired. If not, I cannot help you. You have to think ahead. You have to think a step. Yes, that's right. Are the kids home? Yes, they're home. Okay, well, let's make a phone call. Let's call whoever. Let's do whatever. What you're really doing is you're facilitating their goal. And as you are facilitating their goal, you're not creating negative emotional responses, which is the energy to fuel behaviors. And then you can channelize that energy in, okay, well, let's go make some food. Let's go peel some potatoes, then let's make, and then we'll take it home. Makes sense, right? Maybe you don't have grocery, you've been away for a day or two. But try to channelize it on the themes they are expressing. Don't shift gears. Oh, you can do that tomorrow, let's do this now. No. You got to pick up on what they are saying. Be creative and work with them. And I can assure you, it's all a part of what we're going to do over time, is take the scenarios like this and how many times PRNs get used versus not. So that is this particular behavioral expression. Moving on to the next expression in this category, apathy behaviors. The symptoms of apathy behaviors is indifference or lack of concern regarding oneself or their environment, lack of self-initiation, low social engagement, poor persistence, and then, of course, emotional indifference or lack of emotional remorse. Now, on the surface, it conjures up a few ways of understanding, but hopefully I can tell you how it isn't what you're thinking it is. So, go back to the basics. If goal-directed behaviors were because of impairment in motivational circuits, the impairment was there was too much motivation. That's why they were busy beavers. Too much determination. Here, because there is impairment, because there is absence, even the ability to recognize that discrepancy. So there is loss of recognition of that discrepancy between self and environment. And the best example you all know is people who don't want to take a bath. And yet, they will tell you they're fine, they're clean. Because they don't see that. We go do home visits. homes which are cluttered and there's all kinds of senile squalor syndromes. Again, that discrepancy. They don't see that there is it's not that they don't see, they lack the ability to recognize. I should rephrase. They lack the ability to see. And that's the key distinction. There is absence of appreciation of the difference. One is to see it and not do it. And the other is to not be able to see it. Here, they're not able to see it. And so what happens? There is no need identification. They don't see that everything around them is clean. Everybody else comes in new clothes every day. They have the same clothes on for the last 2 weeks. But they lack the ability to see that difference between themselves and the environment. And therefore, there is no goal identification, which means there is no motivation to fulfill that need, which means they will not attend to their basic instrumental social functions, not because they don't feel like it, not because they don't want to, because they fail to recognize that there is something the matter. And the same with the milieu. When we talk about lack of initiation, well, obviously, right? I mean, if you don't recognize a need, you don't identify a goal, there is no motivation. So why will they self-initiate anything? I mean, that's a contradiction. And when they don't self-initiate, you can put all the power, you can move all the machinery around them. Even if they take a step, it fizzles out really fast. Because motivation is persistent, voluntary effort. That persistent, voluntary effort, in this case, is not there. And it's not there because they lack the ability to recognize that discrepancy, and therefore there is no generation of motivation. The important thing here is this last bullet, which is emotional indifference. And this is where we get into a lot of challenges. You know the kind of person we're talking about? They look fine, and we're getting frustrated. We're getting upset as care providers, as family members. And we're losing our cool. We're starting to rant and rave, but they cannot recognize that discrepancy between their internal emotional state and us losing it. And they have a little smile on their face. Happens all the time. It's not because they are, they're smirking because you're acting funny. So even after we do all of this, we expect them to perform and they don't, then the least we expect from them is apologize. But they lack the ability to express remorse. They don't feel it. And so this is how this category escalates. So the important thing here is to understand these people with dementia lack the insight into lack of care for self and others. So it's a double negative. It isn't that they see it, they don't want to do it. It isn't that they're trying to give you a hard time. It's just that they lack the insight. And that applies to even expression of emotional remorse. They lack that ability. So how is it different from depression? Because I know everybody was thinking about depression. It isn't. People who have depression will acknowledge, but they'll make excuses. I I don't need, I did that the other day, no problem, whatever. They'll give you, but the key is they recognize they haven't done it. They recognize there is a need to do it. Similarly, people with depression will acknowledge a state of amotivation. Oh, I'm too tired. I just don't have the energy. I don't have the motivation. I don't have the ambition to want to do this. And instead of lack of remorse, people with depression are riddled with sense of self-responsibility and guilt. The infamous Siggy Caps only has guilt in it. G, Siggy Caps. G is the guilt. That is what hallmarks depression. So it's just the converse. And it's important to know the difference, because giving them antidepressants is not going to do a damn thing. But because they don't move, they all get it. Cipralex and Celexa and the whole rest of it. Now, what is the purpose of this measure? The purpose, and I'm using this idiom in a most respectful way. If you Google it, there are many different ways, but it's really for you. When you see this, it is important as healthcare providers to say that this is more of a bump on a log. You know, the protuberance on a log, it never goes anywhere. It's an eyesore, but never goes anywhere. But it really is to help you understand the inactive or inert state. That bump on a log, that protuberance is inert, it's inactive, it doesn't go anywhere. You can come back now, 20 years from now, that bump is still there. So it kind of reflects this cohort of people. If you have to understand the purpose of what is happening. And then what's the meaning of this behavior? I think the meaning from this individual's perspective is, don't judge me as being lazy and difficult. Understand what's happening to me. I have lost my ability to recognize that there is a concern. I have lost my ability to show you emotionally that I acknowledge you're upset with my behaviors. Because oftentimes, people like these also are the ones who have frontal lobe dementias and certainly talk the talk. And then you get into these struggles with them. So this is what they are telling you. The purpose is to say, this is a situation equivalent to bump on a log. And approach to care, you guys know more than I do. I just filled the slide. I don't know. You guys know you do a fabulous job, however you do it. So I'm just going to skip this because you guys should tell me how you deal with it. It's tough. Really tough and challenging. But that still doesn't mean, that still we need to understand what it means and what it does not mean, more importantly. Moving on to the next behavioral category, importuning behaviors. Again, it's one of those behavioral categories that is because of impairment in motivational circuits. And what we've said was, if goal-directed behaviors were resulting in excessive motivation because of disease state, apathy behaviors is absence of motivation because of disease state. But the reason for that absence is lack of ability to appreciate importuning behaviors. Behaving in ways for demands to be met immediately, shadowing staff, kind of being a pest, crowding personal spaces of healthcare staff, and then attention-seeking and manipulative behaviors. So, a little history on importuning. The definition of importuning is very simple. Persistent or incessant, and pressing. So one is, they are making those requests persistently. And the second is they're pressing at you. with those requests. What's interesting, though, is to recognize the requests can be expressed in a few different ways. One of the ways in which a request can be expressed is overt or obvious. Another way to express a request is occult. You know, occult fecal, occult blood, occult hidden. And then another way to express a request is ambiguous or unclear. And what's important is to remember the way in which a request comes to you is determined by the stage of dementia. So if I have mild dementia, my requests could be fairly overt or obvious. I need to go pee, I'm hungry, my tummy hurts. No problems with that. That's easy, but we don't deal with mild dementias. If, on the other hand, the dementia now is moderate, then it becomes more hidden. We have to sift through it. We have to try to understand it. So, they'll just come stand around us. They'll shadow us at medication passes. How many times the nurses struggle giving out medication? They can't even leave their vow, whatever you call it, the computer on wheels. They have to lock it up because these guys are circling around. Or ringing bell, calling for family. That's obvious, but what they want is not. It's hidden in that behavior. And that happens in moderate dementias. And then, of course, the bane of our existence is we only deal with advanced dementias, where the requests for what they want versus what they're showing is completely ambiguous, completely unclear. Laying down on the floor, rummaging through garbage and bringing it to the staff. Repeatedly removing their continent product and handing it to the nurse. So they're trying to tell us something. It certainly is not clear. It's anything but clear from their behavioral expressions what it is. But they are trying to tell you something. So what is the purpose of this measure from your perspective? The purpose of this measure from your perspective, when you see those ambiguous or unclear or occult and hidden requests, is in this person with dementia, there are some unmet basic needs. When we talked about goal-directed behaviors, we talked about the belongingness need. This here speaks to unmet basic needs. So what is the person with dementia trying to communicate to you? What is the meaning? What they're saying to you is, please help me to identify my specific innate physiological need which needs to be met. I just can't tell you. And what are the innate physiological needs as human beings? Hunger and thirst, voiding, defecating, fatigue, need to rest, pain and discomfort, mental and social stimulation, and need for intimacy. And I'm using the word intimacy that we use in dementia literature, not for sexuality. These are the innate physiological needs which this person is saying, help me identify which of these it is, because I cannot tell you what it is. So what is the approach to care? The important thing to recognize as healthcare providers is the majority of the requests will be hidden, occult, or unclear. And for the same behavioral expression, it could be different needs at different times of the day. So it doesn't mean that you'll have different behavioral expressions, but the manifestation of that expression is categorized under importuning behaviors. I mean, we always get the family involved, but this is where you need to get more information from the family. Tell me more about this person and how they expressed their needs and how they met their needs in this domain and all of that. Because you have to make some sense. And if you can't, then you're really stuck with having to rule out each need for every time they express to see, you're ruling out everything. Is it this? Is it this? Is it this? And hopefully you'll stumble upon something and it doesn't change the next time. But the important thing is, because the vast majority of these needs are hidden or unclear, it's very easy for us to label them as quote-unquote attention-seeking or manipulative. Because the need is so far removed from the expression, and it becomes a problem. So the purpose of the measure is that this person's basic needs are unmet, and the meaning of the behavior is this person is asking you, reaching out to you and saying, help me identify which of my innate physiological needs is it, because I cannot tell you anymore, and work with that as best as you can. And with some of these approach to care, I'm simply giving you constructs. You guys are much better at this than I am. I will admit that any given day. I just talk theory. You guys live it. One of the things I'm going to do is take it out into the trenches and have people help me develop these non-farm interventions. Because you have the ways to do it. You do it. Intuitively, you all do it, as I've said. I'm just putting some scientific parameters around it, some way to help you understand and categorize. But this is what it is. So the last category in this is motor behaviors. So the symptoms in this category, roaming, strolling, wandering, fidgety, rocking in the wheelchair, restless. Again, I should have put agitated in quotation, because it means differently to different people. Seemingly driven on the go, wheelchair propelling, whether it's foot propelling or arm propelling, chair exiting, bed exiting, all of those things. Now, the alternative terminology that exists in the literature to label and describe these behavioral expressions. And one of the things so far you may have heard say repeatedly is behavioral expressions. As of yet, I have not used the word responsive behaviors. And there's a reason for that, but I didn't want to get into it here. And I can speak to that briefly. So far, we're dealing with behavioral expressions. Because in my way of understanding, there is a distinction between behavioral expressions and responsive behaviors. And I'll help you understand that a bit later. So the alternative terminology that has been used is agitation. Now the million-dollar question is, are you labeling agitation as defined in mental health literature? Or are you labeling agitation as it should be with Cohen-Mansfield? What I do know, and I'm willing to put a wager, 99.9% of the time, when we're labeling people as agitation, it is according to definitions of mental health. And we're simply talking about a symptom, not a syndrome. And one of the things we know in science, garbage in, garbage out. So you can take agitation and keep treating it, and they don't get better. The other alternative terminology, which I really like, and which sort of took momentum for a while, but then it kind of dropped off, and I haven't seen much of, is wandering behaviors. And the reason why this is way, way better than agitation any day, I prefer people not use agitation at all, unless they're using Cohen-Mansfield, and then we've talked about the limitations, is the literature has often said the least you can do is, if you see wandering behavior, is to look at, is it purposeful? Again, not from the person's perspective, because there's always a meaning to it, but from your perspective, is, do you see a purpose in that wandering, or do you see no purpose in as much as you can understand? And the best example I can give you is, if I am unsettled, I could be just pacing up and down, musing, thinking, which may seem to someone, the guy's just going up and down to no purpose. Or I can be unsettled and move things around, put things away, take things out, whatever. On the surface, it'll appear to be purposeful. Now, there is purpose to the other as well. I'm thinking, I'm problem solving, I'm worrying about things, but it's not obvious to you. If I can't communicate, it's not obvious to you. So the important thing is, here when we talk about the differentiation, it's more from the perspective of us, not the person with dementia, because for them, everything has a meaning. From us, we sometimes will label things. But regardless of how you label this, I think the important thing to understand is what really happens just in terms of the motor behaviors is, it really is about frequency of motor activity and the amplitude of motor activity. And it's a continuum, low to fast. If I'm doing something more often, it'll look like I'm sped up. And if I'm doing it way less often, it'll look like I'm slowed down. And that's the struggle with this motor behavior, is when do you say it's restlessness? When do you say it's fidgetiness? When do you say it's agitation? When do you say it is what? Because that's all relative. And what is it relative to? By the layout. I'm just going to go to the third bullet. The layout. If it's a crowded place, everybody is super agitated. And if it's a big, expansive place, it may be meandering or wandering or just being unsettled. So there's a lot of that subjectivity that comes in. But the important thing, of course, is that these behaviors are the most ubiquitous behaviors. They're like daylight. Everybody's got them. And they are the ones that often are the reasons for the referrals. The person is quote-unquote agitated. Please come see the person. The most common reason for referral. But really what's important here is to understand that that is just but a reflection of what this person is thinking. So really, the purpose of this measure for you guys is, what I really meant to say was existence of an unsettled mental state. Their mind is unsettled. It's what's in the mind that determines what you do in the body. Don't focus on the up and down. Try to focus on the mind. So it's an unsettled state of mind. We don't know what it is. What the person is saying to you is, I cannot express to you. I don't know, or I can't express to you my reasons for being unsettled. But do me a favor, at least if nothing else, as a point of start, see if it appears purposeful or purposeless. And then move that on, pass that information on. Because from what you've seen so far, just the behavioral categories you've seen, it could be purposeful with all the categories we've talked about. You can have motor behaviors with misidentification behaviors. So motor behaviors are a subset of misidentification behaviors. Motor behaviors could be a subset of goal-directed behaviors. Motor behaviors are a subset of importuning behaviors, all of which there's a purpose. But if you don't recognize that purpose, in misidentification, you don't recognize there's a mismatch happening. In goal-directed behaviors, you don't recognize there's a discrepancy and the need to belong. And in importuning behaviors, if you don't recognize the purpose and the need for basic needs to be satiated, then you'll simply label it as an agitation. And that does nothing. So the idea here is motor behaviors will never occur in isolation. We have to learn to pair them with each of the other behavioral categories. And then it helps us understand if it's purposeful. And the place to begin is to start by saying, on the surface, what does it appear? Purposeful, purposeless. Then it narrows it down for you as to which of those behavioral categories you're searching for. If you don't know. So again, the important thing to approach to care is to learn to make that distinction. Is it purposeful or purposeless from just observing? Then at least you know if it's purposeful, you can rule out some of the other behavioral categories. You know it's not going to happen in apathy behaviors. You know it's not unlikely to happen when you have a functional decline in disorganized behaviors. So at least two you've ruled out. The others you have, and as we go through it, you can start to pair for yourself. Where else can it belong, and in what and what does it do? And if it is purposeful, then we've already established what the person is saying to you is one of two things. I require fulfillment of belongingness needs, or I require fulfillment of innate physiological needs. So you can plan accordingly. Food for thought, and you can, again, as we go down, and that's one of the reasons why, if you've seen the scale, motor behaviors is the very last behavior on that scale, because by itself it's the most useless behavior. We spend all this time chasing quote-unquote agitation, but in itself, unless I can pair it. So if it's appearing purposeless, then here's the food for thought. Put it to your own perspective. When do you sort of walk around up and down in your house, on the street, or wherever, when you're worried, when you're afraid, or when you're worried? So the purposeless is not purposeless, it's appearing purposeless to us. But for them, it's a way of expressing their energy because they're worrying or afraid. And you'll become more obvious as we go through other behavioral categories. But I just wanted to throw it out there. And then care plan accordingly.